My name is Michelle Chee. I am a clinical assistant professor at the University of Washington in neurology. That just means I'm a general neurologist, so that means I see patients who might or might not have a neurological problem, who some other doctor thought they had a neurological problem, which can be a wide variety of things, including strokes, seizures, headaches, what we call neuropathy, which is any sort of nerve damage, but really just any strange tingle that people have, mysterious weakness. People are worried they have MS or ALS or dementia, any of those things, or none of them. And depending on what I find out, I work only outpatient. I don't work in the hospital currently, so people come to a clinic, I talk to them for an hour, I do an exam, and then I decide if A, there's nothing wrong with them and they don't need to see me again. B, there might be something wrong with them and I need to do some tests and then they need to come back. C, there's definitely something wrong and they need to go see someone else, because some of these problems I don't manage for myself. If I diagnose someone with seizures, for example, or headaches, I can definitely keep them and there's a good amount that I'm comfortable managing myself. But it's kind of up to me to decide at what point I need to refer them to a special epilepsy doctor. But there are some diseases like MS, like cancer, that as soon as you diagnose that, it's definitely not the job of a general neurologist anymore. You need to send them quickly to a specialist. Mm-hmm. And the last part was, how did I get here? I have a pretty traditional path. I went to college, I studied neuroscience and Spanish, and then I went to medical school, and then I essentially went straight through and did my neurology residency at the University of Washington. So I've been in Seattle. This is my 5th year. It's, when I say outpatient, it's pretty similar to just like how you're normally used to going to the doctor. I worked at a clinic. The first patient comes at 8 a.m. They tell me I have 1 hour to try to understand what they think the problem is, whether I have a different idea about what the problem is. I take a history, which just means I ask them everything about this problem. I do a physical exam. And then, like I said, I decide if I'm going to do any testing, which is either imaging, MRI. Well, someone once told me neurologists only have 3 tests, which is an MRI, an EEG, and a lumbar puncture. In an outpatient setting, you can add an EMG, which is the electrical test that sort of directly measures the functioning of your muscles and nerves. Sometimes some blood draws. So I decide if I'm going to do any testing. If they're in pain typically, or they have something that needs to get treated right away, sometimes I'll try an empiric treatment before I know exactly what's wrong with them. And then I tell them to go away and try my treatment or do my testing and come back in 2 or 3 months usually. And I see, I'm lucky, honestly. I see only about like 6 to 8 patients per day, which is pretty, which to me feels very reasonable, and I think for some people might even feel they could probably do more, but this is my first year doing this job, so I like this pace. I think the biggest thing is it helps you know how to read research. I definitely don't see myself doing basic science in the future. I could consider doing probably if I continue into oncology, I'll participate in clinical trials. And I think it's an exciting time someone told me when I was in med school, cardiology's time was like 30 or 40 years ago, but this is like neurology's time, and it's a really exciting time to be in neurology and neuroscience, and so there's a lot of new research coming out, and you really need to be able to read that research yourself and sort of evaluate whether this is like of a standard that would make you want to actually take this new idea and apply it in your clinic. I mean, I think the biggest challenge, you're catching me at a stage, like I said, this is my first year as an attending. Right. So the biggest challenge is that there's no one standing behind me anymore, and I'm comfortable. The nice thing about staying at the institution where I trained is I have a lot of people that I already know, and I'm comfortable with asking them. So I definitely have attendings that were my teachers during residency that I continue to write to ask questions, but it's up to me to decide when it's time to ask the question. So I think that is a new pressure that everyone has to experience as a first year attending. And how do I deal with that? I think I'm comforted by being able to take my time. Like, it's okay to tell the patient I don't know and I need to do more research, and actually they tend to appreciate that. They like that I am not brushing them off, that I am taking them seriously, and if I say I don't know but I'll get back to you, that's all. It tends to be well received. So I think just taking my time, accepting that I'm gonna be slow, but I want to do it right, and being okay with asking for help. I wish I had more collaboration, honestly, in my day-to-day. That's one of the reasons I am thinking of going into oncology, because something that I like about onc and certain other little pockets of medicine is that it's very interdisciplinary. If you're treating for pretty much any type of cancer, but certainly for brain cancer, you need a neuro-oncologist, a neurosurgeon. This is the people who are at Tumor Board, which is a meeting where we discuss new or difficult cancer patients. There's a neuro-oncologist, a neurosurgeon, a neuroradiologist, a neuropathologist, and a radiation oncologist. And it's pretty much every neuro-onc patient needs all 5 of those disciplines, and you talk to all those people. And I think I'm gonna like that more. Currently, like I said, I do ask for help, but it's only initiated by me, like when I am confused. Mm-hmm. If everything is routine, then I don't really need to collaborate with anyone. I just make a decision and I do whatever I want. I was thinking about this, and I think something that's really exciting is, again, not in my current daily work, but I'm going to do an oncology fellowship at the Alvord Brain Tumor Center next year. And neuro-onc diagnostics have really evolved very rapidly in the last several years to a point where it's actually changing the way that we classify brain tumors. So we used to classify them, probably not. I was thinking if you guys would be familiar, but there's a histologic classification, which means you cut it up and look at a slide and you look for certain markers of cell division just by the way it visually looks. Like how big are the nuclei and how many cells do you see that are currently in the process of division, and just do you see any evidence of necrosis, cells that have been growing so fast that they're just dying because they can't coordinate themselves. And then more recently, we have evolved into a molecular classification of tumors, which when you go back and look at old tissue banks, seems like it makes more sense. We used to be how could it, we don't understand why we are grouping all these tumors together as oligodendrogliomas, but some of these people are living much longer than others. And so now we're learning what's different about that group of people. And it's because of certain mutations that they have. And we are also, even more excitingly, finding ways to target those mutations, which obviously has implications for therapeutics. So I think that's very interesting. That makes it, in addition to being an exciting time to go into neurology, an exciting time to go into neuro-oncology, which is a field that actually hasn't had a lot of progress in terms of longevity of patients for many years now. So this is an exciting time where we might start to finally see that. The things that I like about neuro-onc, like I said, I do like that it's very team and interdisciplinary based. I like that there's a lot of palliative care that's involved. Palliative care, for people who aren't as familiar, is a branch of medicine that's relatively recently evolved that involves treating symptoms. It can happen at the same time as treatment with intent to cure. So cancer patients can be getting chemotherapy, going on clinical trials, and at the same time they can have a palliative care team that's treating their nausea, their pain, their spiritual distress, helping them talk to their children about their diagnosis. So it's just based on symptom alleviation and just quality of life kind of in the present moment, which often does not have to conflict with life-sustaining treatment. sometimes it does, and then there are conversations about that. So I like the palliative care aspect, interdisciplinary. What else? Also, just from a systems perspective, I think a lot of doctors and just a lot of people in general are frustrated with the way that the American healthcare system works or doesn't work, certain diseases have gotten a lot more attention because, I don't know, because prominent people have gotten them, or because they just, for some reason, seem extra sad to the general population, and so they get funded and they get these centers. So like we have Fred Hutch here in Seattle, many cities have their own cancer center. Those places are just places that I think care for patients works in the way that it should everywhere, where there's associated social work, there's psychology, there's, like I said, palliative care, there's just like patients get these like wraparound services. Like Fred Hutch has housing, actually, for neuro chemo is not that immune suppressing. But if, for example, you're getting chemotherapy for like lymphoma or something that's going to really suppress your immune system, they have special housing for you to live in. There's a chemo bus that will take you from the housing to chemo or radiation and back every day. And they will pay for the patient and a caregiver to stay. I don't know how, if all the patients can get that, but these kind of things are things that I think treatment, it's very hard for treatment to succeed without these kind of services for certain patients. And I think things like oncology, things like ALS, are just places where, for whatever reason, we have put systems into place that like really help us take care of patients better, and it's just more satisfying. Yes, yeah, I mean, it was a great experience. It's, I think, honestly, my favorite thing that I did in college. And I'm so sorry, what was the question about it?
It's kind of like, how's that experience kind of shaped you now? And influenced your work now?
Okay. I mean, I think on a very practical level, I use the Spanish pretty frequently. I speak pretty fluent Spanish now. And I think patients are always sort of impressed and surprised by that. It gives me some good initial brownie points with them. You do meet a lot of strangers as a doctor. You spend most of your day like meeting a new stranger, and so anything that gets an initial in with them is helpful, especially in the United States, for a population that frequently has been mistreated or undertreated by the medical system. I do think it made me very aware and sensitive to the way that medical care can easily become unequal for patients that don't speak English as their first language. So I'm a big advocate for the proper use of interpreters. I think that's something that was taught to me in med school, like that it's like necessary to use an interpreter, and you can't just go by with your, low-level high school Spanish. But it became more obvious once I became fluent in Spanish, and then I could, just see the types of conversations that were had and how they were just not of the same depth compared to conversations that were had with English-speaking patients. And so I think I'm a real stickler for using an interpreter, and a big advocate. Harborview has a program called Cultural Navigators, which is really cool, and actually influenced my desire to come here to the University of Washington residency program, because I felt like the UW healthcare system, at least in that one way, was consistent with this value that I have of providing equal care to people who don't speak English as their first language.
Yeah. And then
I always start the conversations telling people, like, it's also okay if you don't want to be a doctor. Like, I like this job, and maybe that's what I would tell my past self, is like, just realize that this is a very people-facing profession. And luckily for me, I do think I turned out to be someone who likes to meet a bunch of strangers every day and listen to their whole life story, but like that can be quite tiring. I don't know, there's so many things about medicine that are difficult to describe, and even if you describe them, it's difficult to really know how they'll impact you and anything that I did, because it ended up great. And also, I just don't think there's anything I could say to my past self that would make me change my mind. Like, I was a very, as I'm sure many of you are, like, you know, a kid that was good at high school and good at college, and I thought everything was going to be easy for me forever, and I don't think anything that an adult me would say would deter that person. And I also don't think I would want to.
That's very cool. Like, you've written to it from the start.
Yeah, I mean, I think I've gotten, like, more tired and a little bit less infinitely confident in myself. You know, I think, like I said, as a high school and as a college student, I was like, people said Calc 2 was going to be hard for me, and it wasn't. So being a doctor is probably not hard either. Right. And now I'm like, oh, being a doctor is hard, but it also is something that I like and I want to do. So that's why it's hard for me to think of something to say to that, because I don't want to change that trajectory, and I also don't think anything that I said would have changed that trajectory. Like, if someone came from the future and was like, being a doctor is really hard, I'd be like, okay, that's what I said about Calc 2.
Very cool. Very cool.
So I talked about Spanish, but I also really wanted to take this moment to talk about some advocacy that I do that has nothing to do with neuroscience at all. But I do think it's very important for doctors in general, and I suppose just scientists and people in this field to do advocacy. Someone told me when I was in med school that I was going to have a platform as a physician, and that's not something that I really thought about before entering this field. Like, there's a lot of things I wanted out of medicine, but having a platform wasn't specifically one of them. But I think if you're gonna get a doctorate, for example, of any sort, people are gonna listen to you a little bit more. And it's nice, if possible, to use that power for something. The advocacy that I've sort of fallen into has to do with tuberculosis, which is the world's deadliest infectious disease. In case people didn't know, there are 10,000 cases annually in the United States. Most of those people don't die. But worldwide, 1.25 million people die every year of tuberculosis, which is a completely curable, treatable, and preventable disease. And so I actually got into it through this internet community that I'm part of. But it's been great. I think it's great to have an issue, just to pick any issue. I like that this is at least public health related, so it feels like it's a little relevant to being a physician. And I can sometimes throw that weight around for good. And I like that there's a community around it, that I was already sort of part of. So it's nice to do advocacy with other people. And we're going to Capitol Hill in April, and I'm going to speak to Washington representatives about tuberculosis. So I'm very excited about that. I think I have this sense from studying just almost anything. Like, if you study any subject enough, you start to see it everywhere. I think that's one of the fun things about just studying in general. I was about to say about biology, and then I was like, well, also chemistry, also physics, also math, also like literature and anthropology, and just anything that you get really, really deep into, you can, just start to see it everywhere. And it makes me feel cool. It makes me feel like I have like a secret, like Sherlock Holmes key to know about people. Sometimes in that you feel like you can like spot someone with Parkinson's disease. You can just have a very specific walk and a specific face, and if you've seen a couple, you can just kind of tell. And sometimes just in the sort of concept that there's just so many layers. It's something that I like about neuroscience, that you can study it at a very micro versus and a very macro level, and those things can relate to each other in a way that I think is very sort of just intellectually cool, sort of tickles my brain. Yeah, I like to sing. I'm with the choir in Seattle called Wellspring Ensemble. We have concerts 3 times a year.
I guess, is there anything else like afterwards specifically that sort of relax by?
What was that?
Like anything afterward that helps you relax a little bit?
Oh, specifically like right after work? I like to run, although sometimes it's too dark in Seattle and I don't feel like it. But there is, again, a group called Green Lake Running Group I like to run with sometimes. I really want to get a dog, but we're not there yet. I like to cross stitch. Yeah, sometimes I cook. I'm not really good at it.
And then our last question is there
I think this is going to be an audience of very smart and highly motivated people, and I think I like to tell them that it's a marathon and not a sprint. And if you don't take breaks, that will be a problem at some point. So it's good to cultivate a habit of being nice to yourself. And people tell me all the time that I'm too hard on myself, so don't make that mistake. Don't be too hard on yourselves. You're doing great. If you're not doing great, you will be doing great in the future. It's okay, and it's actually better to take breaks. Because both for your own sake and for the sake of the work you're trying to